right, Neka, thank you so much. We greatly appreciate that. A lot of information was passed there, basically asking the question, what do we need to do to achieve quality healthcare in this part of the world? And that now moves us wonderfully into the panel that we're now sitting on, which is digitization for smarter healthcare delivery in emerging markets. So I'm going to hand over to our panelist, Olufemi Kuti, who will now take us through, and then have our fellow panelists just talk through what are the innovative ways in which we can ensure the dream of MDoc is achieved in this part of the world, and relatively soon, according to those statistics of those of us, if we do not change our lifestyle habits, what could possibly happen. Not to be doomy and gloomy, but it's important to talk through innovations. All right.
Thank you very much. Good afternoon, everybody. It's been a great introduction from the keynote. And I think the role of this panel is that we're going to be going further in depth into a lot of the points that Dr. Necker raised. I will go straight in. I can't think of a better assembly of people to be able to address these questions. We'll start with buy-in. We are at a time where primary care is very important, but the kind of primary care that we're addressing in Africa now is the double burden of disease. So we're still addressing issues with malaria, HIV, but we're also having problems with lifestyle illnesses, hypertension, diabetes. You build technology for a living. You work with technology. What kind of interesting inventions and technology pieces are we seeing today that can address these primary care issues?
Great. So we know that there's general trends in primary care and how primary care is being delivered. We work at FIO, we work across all of Africa, along with India and South America. And the general trend is to push primary care as far as possible into the periphery of the healthcare system. That's general primary care, but additional surface such as diagnostics and preventative care. The challenge there, of course, is how do you do that while maintaining high quality care delivery and also addressing the challenges associated with a decentralized setting. There's a number of approaches around that. So what we've seen is that the key is to deliver solutions that upscale the capability of health workers that are in the decentralized settings, while at the same time maintaining that quality of care. So for example, just to touch on an example, at FIO what we do is we employ a solution that is built to deal with the decentralized setting challenges. You know, low infrastructure, lack of skilled health workers, fragile connectivity. And so we build this mobile-first solution, and the solution kind of upscales the capability of the health worker by giving them, you know, the power of machine intelligence to be able to do things like appropriately do diagnostic testing, right? Now, at the same time, you need to build these solutions in a certain way. It needs to add value to the process of healthcare delivery in the primary care. You know, again, to leverage an example, what we do is we build these machine learning algorithms to provide on-the-spot training of the health worker as they deliver care, seamlessly giving them feedback, basically upscaling their capabilities and giving them training on the spot, right? So that gives them this, I guess, credibility for the software that they're using, which makes them want to use it more. And by using it more, they're learning more, and the beneficiary of this is the patient because they're getting better quality care. Now, the final pieces of all this is, of course, is to build these solutions in a way that they're appropriately priced with the right business model, and they are sustainable by working with the appropriate partners. Disease management in general is not just about one care encounter. It's about being able to track the patient's traversal through the care continuum, their journey through the care system. And of course, you need to partner for that. You need to build technical solutions to be able to do connectivity. And of course, you need partners such as InterSwitch to be able to figure out how to process the payments around that and to be able to have the on-the-ground presence to implement such solutions.
Dr. Necker, Bayan has spoken a lot about technology solutions for the provider side and for the doctor side. Do you want to tell us some of the things that apply more directly to patients, especially in your experience?
Absolutely. So we've interviewed patients across the world, and they more or less define quality in the same way. They say, first of all, when I access healthcare, whether it's remotely or in a facility, number one, do not harm me. Number two, heal me. Number three, be nice to me, in that order. So we're seeing a lot of solutions really trying to address that. We have an activated health user group now. People are coming to the facilities with their mobile phones and Google and putting providers on, telling them, if you don't know this, we're going to push your knowledge. So we need to do more of that in a much more streamlined and useful way. We need to educate the health user and the health consumer. And there's a lot of mobile platforms that are doing more on educating and empowering the consumer. There's a lot more, too, around essentially helping them take charge. This is what we're doing. So our focus is chronic disease. And I highlighted the four modifiable risk factors: diet, nutrition, physical activity, but then also smoking and alcohol. It's very much about behavior. We know what we need to do to lose weight, as an example, but we're not doing it. So we're leveraging our platform to support health users directly on creating their own personal goals in terms of these risk factors, supporting them along the way with technology in making change, tracking that, feeding that data back to them, and then showing what the improvements are, and at the same time highlighting what needs to be done. We're seeing that really across the world. And that's why we can really help to start addressing this preventative piece more remotely. But at the same time, MDoc and many others out there are working side by side with the provider. So we're essentially sharing this data with them. At the same time, we're working to build their capability so that when that hypertensive patient comes in, the physician, the nurse, the community health worker knows how to manage her or him effectively. So it's a holistic approach to primary care and preventative care.
That's a great point. I think one trend that we're beginning to notice here is the fact that technology is a supporter.
Yeah.
So it's supporting you, either you're a provider, it's supporting you if you're a patient as well. And one very important set of people in the healthcare ecosystem are healthcare professionals: doctors, nurses, community health workers. Dr. Wallace, this question is directed to you. We're in an environment where doctors, for example, in Nigeria, are 1/10 of the WHO standard or the WHO expectation. What kind of technologies can we make use of to either stem or capitalize on the brain drain that seems to be an inevitable economic situation, if I can put it like that? What other ideas do you have for that?
Thank you for asking that question, and thank you for asking me to speak about technology. My day job is an orthopedic surgeon. I practice both here and abroad. I have a great passion for health. I kind of represent a new group of doctors, majority of them in Nigeria, some of them abroad, who kind of believe we need to do things differently. There are loads of changes happening everywhere, especially in Africa. But one thing that is consistent is the statistics have remained the same. If you look at infant mortality 10 years ago, now it's about the same. Immunization 10 years ago, now about the same. Nothing is changing. So maybe we should be asking ourselves, what are we doing wrong? What should we be doing? And a group of us have been asking that question for the past few years. And it is our belief that Africa at the moment, we are kind of opportune and we are kind of in an advantaged position. You probably say the statistics don't prove this, but health, unfortunately, is the last major industry to really get into technology worldwide. So if you go to Europe, you go to America, health lags behind everywhere else. So they are now catching on. They are now trying to improve. So what we are trying to do, everywhere in the world, they are trying to do it better. But our advantage is that they don't have the problems. So they are trying to create solutions for what is a successful healthcare. While we in Africa, we are trying to create solutions with problems we have. So we should begin to concentrate on those problems and solving them. We should be solving them in unique fashions. I don't, unfortunately, see it happening at the moment. We are bringing technology that works elsewhere and trying to make them work for us. But it doesn't recognize our unique position. So let's try and, how would I do it? I'll give you a simple example. It doesn't have to be the correct example. Nika said half of the people in this room will have hypertension. That's correct. If you look at one of the greatest killers in Africa, high blood pressure. Now, why don't we say from now on, everybody over this age, compulsorily, you have to have your blood pressure taken for you to get your wages. So that's the start point. Then technology comes in, whereby it protects you as the person. Obviously you don't want your employers to know your blood pressure. You don't want everybody else to know about it. So it then comes in to be able to achieve that. Now, what would happen is, because we all know our blood pressure, the people with hypertensive are picked up very early. They are treated very early, and it's easy to treat those early complications. And therefore, the skilled doctors are not then required. So all of a sudden, we've taken a problem, we've applied a unique way of solving that problem. A unique African way, a unique Nigerian way. And the solution it's been helped by technology, and we then achieve a very successful outcome. And I basically, with a group of other people, we've tried creating solutions that recognizes Nigeria as a way of doing it. And one of our solutions, there are quite a lot of EMRs around. And all of them, it's all based on the same way, the same way that don't recognize what we really lack in Africa is our process. It is not collecting the data. Yeah, it's nice to collect the data, but what do you do with the data when it's been skewed by bad processes? And we had focused on just creating the processes that will deliver the consistent healthcare, and therefore whatever we are getting, is the best for Africa. And I think that's the way, to really help in achieving a successful technology-driven healthcare in Africa.
Yeah, I still want us to spend some more time focusing on, healthcare professionals, and one big part of that is training. Dr. Jumoke, you're a research scientist, and you're also very involved in STEM training. Can you talk to us about some technology pieces that, yes, we do agree that we are having a drain of doctors who are leaving the country and healthcare professionals generally, but there's also, as was touched on at the keynote, that need for training and the need for education. Is there anything that technology can do to help, bridge that gap for professionals who are still within the country?
Yes, absolutely. So apart from what technology can do, which I'll talk about in a minute, each and every one of us has a key role to play in the success of research and in the success of healthcare in this country. I say that, but what I mean is there's the stigma that healthcare is the government's responsibility, which is the case in many Western countries. But unfortunately in Nigeria, we find that the main funders of healthcare are the private sectors. We should stop allocating the responsibility to the government. Each and every one of us should take active responsibility in our fields. So the healthcare provider, the healthcare professional, the healthcare worker should understand that it's also their responsibility to equip themselves with the knowledge they require. If there's a piece of kit in their facility, they should take up that responsibility to learn how to use it properly, disseminate the data so that you can use the data accurately, you can use it to drive change. We need to introduce research into our universities. I know that there is some semblance of research, but it is nothing compared to what is required for us to match up with the Western market, or even to come to par, to a level that we are able to handle our own healthcare issues in Nigeria by ourselves. I'll give you a small example. I attended the University of Lagos, and all through my 4 years of education, we had a sequencing machine in the lab. Did we ever use it? No. Not even the lecturers, not even the professors or the doctors ever demonstrated how to use that machine. At that time, I never knew I was going to pursue a higher education elsewhere outside the country. But I found that having left Nigeria and finding myself in a position where I'm teamed with people who have used this machine extensively, who can probably use them in their sleep, I find that I had to, behind the syllabus that I had for my course, I had to teach myself. Google became my best friend. Wikipedia became my best friend. I had to teach myself. I had to train myself. The theories of how to use these equipments and techniques and the application. I had to learn that on my own because no lecturer in the UK was going to spend their time training me as a Nigerian student on the basics. We can eliminate all of that if we introduce that at the level of our degree level. If we introduce that, you come up with graduates that already know how to, they already have the mindset of research, and that research would drive change. Research would drive positives in their fields. They don't have to spend the extra time to do it retrospectively when they find themselves in their healthcare centers, in the hospitals, in the diagnostic centers. So the summary is education is key. Education is key to making people research-enabled, irrespective of what their career is. The doctor can make himself research-enabled, the nurses, the diagnostic workers, all of us have a part to play in driving this change. In terms of the technologies that can be used and the sort of innovations that can be used to drive this, I have a few slides that I'm hoping I'm going to have some time to share with you at the end of this panel discussion. But there are simple solutions, there are simple changes, subtle changes we can make to our way of thinking, to the way we apply methodologies to treatment, to the way we apply methodologies to detection of diseases, and in my field, cancer, that can drive so much positive change in so little time with manageable resources, affordable resources. We don't need fancy equipment. You don't need $1 million, £1 machines. We can use what we have in the market today to start to generate and to drive positive change, technology-wise.
That's a great point. I think the key point near the end was how can we use the solutions that we have? And one big part of using the solutions that we have is cost. So I want us to talk about the economics of all these technology solutions, because the next question is who's going to pay for it. I'm going to start from Obinia. You work as what we can say a bulk purchaser of healthcare to some extent. How do we develop solutions that are providing quality to the end user, but are also equally balanced in terms of cost and cost constraints?
All right, thanks very much. The single largest change mechanism to arrive at something that is efficient for everyone is one word: coverage, scale. The more people we can get into the net, the cheaper it becomes all around, because we have a base to distribute the costs everywhere. Ultimately, at the end user level, for the patient and for the provider, everyone wants to be paid from a provider perspective and to be able to pay what they can afford to pay, since they don't all have the same level of income. So as a bulk purchaser, the value that we need to deliver to both customer bases in our mind is a fair payment in exchange for the service that the provider renders, all right? And then for the end user to make it affordable for the person to pay, irrespective of where they sit on the demographic chain, or from an affordability perspective. And the only way to deliver that is to get the scale of people in contributing at their various levels, all right, and you can use that to be able to reallocate based on principles of insurance.
Very interesting. Just stepping off from scale and how it's important that as we spread out, it becomes cheaper for each individual. I want to take this question to Mohammed. You work with the financing of technology infrastructure on a daily basis. I'm sure people here who have heard a few things might be interested in, finding some of these technology pieces and implementing it into their daily lives, be it equipment, be it computers, be it software, et cetera, et cetera. From your own experience, what kind of financing options or access to funds do people have to access to be able to execute these things?
Okay, thank you very much. I'll take it from the supply and the demand side of the equation, right? On the supply side, we require some sort of investment to be able to put the technology in place, to be able to build capacity, as well as ensure sustainability of the technology that has been deployed, right? And to be able to do this, investment is required, okay? So to drive the investment, the demand side must align, all right? So arguably we can say on the demand side, there is demand, but is there credible demand, okay? And this is where we talk about the health insurance scheme, okay? So the private health insurance has to be aligned. The public or national-led health insurance also has to be aligned, right? With all of this properly aligned, we're going to see, investors, the DFIs, the private equity funds, the donor agencies, putting their weight behind the sector. So I'll give you a very good example of what GE has done in East Africa, specifically Kenya. It was a PPP arrangement where about 98 hospitals was equipped, upgraded across about 47 counties, okay? This did not require the government to provide any form of capital expenditure upfront. So it was a bundled arrangement where technology, education, as well as maintenance was put together, and government is required to pay a unitary charge, either on a monthly basis or a quarterly basis over a period of 7 years or more. This is an innovative financing structure, and we're beginning to see more of that being replicated in India, in Europe, and even in Nigeria. Some of these things we're currently exploring in Nigeria.
All right. Okay, my name is Victoria Pelle. I work in InterSwitch, and my question is directed to Nneka Mopison. Okay. So there's a lot of attention being paid to the physical health issues in Africa, and there are many innovations being developed to help the community. But from your experience, do you feel the same level of attention should be paid to non-physical health problems such as drug abuse or other forms of addiction, where people also need help with, and also to help them get better informed on rehabilitation centers or where to get contacts from professionals when they need to find people like child psychologists using the same innovative technology?
Okay, thank you.
Thank you so much. And I say that because when we started, our focus was chronic disease, right? We focused on the big four that contribute to 82% of the premature deaths that we're seeing in this continent. Diabetes, high blood pressure, and then also chronic respiratory diseases and cancer. But I wanted us to also think about mental illness. And mental illness because WHO talks about the billion treatment gap. There's 1 billion people in low and middle income countries that are not diagnosed and that are not accessing the treatment and the support that they need. We have a lot of issues with stigmatization in Nigeria and across Africa with mental health, with substance abuse. We're seeing drug use up the wazoo. People keep on asking, why are we seeing high rates of hepatitis C in Nigeria and South Africa and other countries? Well, look, we're seeing a lot more IV drug use as well. Okay, so the problems of the West are also our problems. But we're cloaked in this denial. When we started talking to chronic disease patients across Africa to understand what their issues were, in Nigeria specifically, people would say, me, I've had diabetes for 10 years, hypertension for 15 years, but chronic disease, hey, don't call that for me. Oh. That's not my portion. So the denial is too much. So what we're trying to do, and we're seeing some others doing this as well, which is essentially help people navigate care, right? So that's providing you with information. If you have a mental illness, if you're worried, we ask 2 questions of you to assess whether you might have depression. And if they're positive, then we ask some more questions. And there's so much evidence that shows that digital coaching in behavioral health can really make transformative change in mental illness. But if we can't only solve that, we can support you, as Dr. Kuti said, but we also help you find that care. So what we've started doing over the last year plus is start mapping healthcare services across Africa. So informal and formal health sector. Think in Nigeria, as an example, our dispensaries, PPMVs, hospitals, clinics. On top of that, we layered that with providers. Because to be frank, when we were looking at diabetes, we're like, are there any podiatrists in Nigeria? Are there any podiatrists in Zambia? We had no clue. When people have mental illness, are there coaches that you can refer them to? If somebody wants youth-friendly family planning, how will she or he find out where to go? So what we're trying to do is put that information in the hand of the consumer in a private way, but in a supportive way, so that they can navigate that care. But we've got to do more. We've got to be comfortable with talking about mental health and all these other non-physical, but physiological issues that can really drive, essentially, improvement if we address them.
My question goes to, my name is Adeshino. I'm a business consultant. My question goes to Obina Abadwe. How are the HMOs using the available technology to advance the coverage in terms of reaching out to the masses in Nigeria, such as using mobile wallets to accumulate up funds whereby people can save in bits, just as the M-TIBA that was discussed by Ineka, something similar that people can actually save up gradually, and when they reach a particular plan, a particular amount that they can actually fit into a particular plan, then they can subscribe and such can be activated. And also the duration of 2 weeks, 1 month, some waiting period of 1 year. How are all those, being restructured? Because, for example, I want to do a plan for my wife and she's pregnant already. Most of the HMOs don't have such plans. Thank you.
Thank you very much for that question. I'll answer the question in 3 parts. The first thing is that historically, all right, there was no cover for anyone who was outside of the corporate environment. Now that's changing. And it's changing, and at Hygia, I'm not promoting ourselves necessarily, but we've got those plans out there where people can buy cover for themselves. Any individual can buy for himself, can buy for dependents, and buy all the way covering up to age 85. Now, you know what had happened in Nigeria historically was that you were with working age, so say 20-something up till about 60. That's when you got coverage, whether you were a private person or a public servant. Once you retire, you drop off. And that's when you're vulnerable and you need the cover, but you don't have any. So that's changing in the market today. The other thing that is happening in the market is that you see many people adopting social media and other online tools to be able to reach the market in a cost-effective way. So a lot of these offers for the retail market are in fact available online. So that's where it is, and there's more coming. The real issue about coverage comes down to affordability. There is no point going to offer a plan that you would have offered a corporate with deep pockets who wants all kinds of things available, and you're taking that to the open market to people who cannot afford to pay for it. So part of what we've tried to do is to change the distribution platform, so partnering with the likes of InterSwitch and looking for how we can get across to people bundles that they can actually afford to pay for, that takes them into the hospitals and gives them ability to accumulate some kind of history, look after themselves a little better, and reduce the risk of bigger ticket items happening. The second thing that is happening as well is to say that the price of plans that we are putting in the market is slowly coming down. So today you can buy a plan that offers basic care for as low as 23,000 naira, which is just a little less than 2,000 naira a month. The big challenge that still exists is about credit. So contracts are written for a year at a time. And the opportunity in there is to see how you can provide some comfort to allow people to pay per month even though they've contracted for a year. And these gaps, even though they exist, all right, there are things that are being resolved continuously. But today in Nigeria, you can buy a plan for as little as 23,000 naira that covers the vast majority of what you may need on a primary care basis with limited secondary care offering. I think it's important for people to understand that healthcare is not cheap. I say it everywhere, it isn't cheap, but it can be affordable, and those things are two different things. It's not cheap because doctors expect to be well paid. If they are not well paid, they will not be happy or satisfied, and therefore will not provide the care and look for alternative environments to work. They need to invest in research, they need to grow themselves, they have the same needs as everyone else, and they expect to be paid for the service that they provide so they too can meet their obligations. So it isn't cheap. Drug companies, facility providers, all of them expect to be paid, right? That's one. But the individual expects the service to be affordable. I.e., if I can only afford to pay X amount a month because that's how much I earn, I should be able to get decent health care on that basis. That's what takes us back to the concept of scale. Unfortunately, or fortunately, the only currently globally tested model is a health insurance platform. Whether it's publicly sponsored or privately sponsored, somebody is bankrolling it and taking the risk of the difference in payment amounts and the timing of payment when events occur. So today in Nigeria, you've got HMOs. That's what they do. So at Hygia, what we do is to try to bridge that gap using principles of insurance. Many people contribute and use them at different points in time. So the money is available for whoever needs it when the person needs it, and for the provider that is providing that service at that point in time. So really, the solution to getting more people covered, and I will answer you about your wife, but the solution to getting more people covered is for more people to sign up to plans. The solution to making the service cheaper for people is for more people to sign on to plans. Because more people signing on to plans allows doctors to make the investments, all right? Allows the people who want to finance equipment, the GEs of this world, all right, that provide equipment, allows them to actually have certainty of payment so they can bring equipment in. Allows drug companies to make investments in the environment to manufacture at lower costs because they can see pools of money that can pay for the service. But everybody that is taking the service is paying small. Now, I think that as an individual, of course, you can go and buy a plan, all right, and we have a plan for you. But if your wife is already pregnant, all right, the reality is that at that point, she's not insurable because the event has already occurred. That is why people need to buy insurance before they have a need. When the event has happened, you cannot buy insurance anymore. There's nothing to insure. There is no probability left. The thing has happened, all right? But beyond that, you can avoid future stockouts by buying today.
Hey, thank you very much. We're going to project a question that we have from Twitter, and that will be our last question for this panel. And it's from Babatunde Abagun that asks, what is the role of medical record privacy goals as an accelerator for scaling digital transformation in healthcare? So I'll ask the question again. It's from Babatunde Abagun, and it is what is the role of medical record privacy goals as an accelerator for scaling digital transformation in healthcare? And that can be addressed by any panelist who has expertise in that.
I'll just take part of it. I think it's extremely important, because that will create, the data for you, to be able to plan, to be able to know the kind of treatment that is required, to be able to adjust the kind of treatment that is required. But the important thing is, how do you create this data? How do you create a system that collects this data for you? And that's where it's important. We know there are the old conventional ways of creating it, whereby you basically input these things. These, unfortunately, are subject to too many variables, and that's why maybe there should be a new way of collecting this data. Maybe rather than you having the ability to input, it should change to you having the ability to select a predetermined data, which will then be aggregated, to give you what you want. But it is extremely important, and I think it's the bedrock of any system, of any healthcare we want to create. We just need to have a foundation, and that helps us in building the foundation.
If I just add
just to add a little bit.
Go ahead.
Oh, sorry. Yeah, thank you. So I agree. I think it's key to understand how you're getting the data, and as you suggest, just like the eClass solution does, collecting data in an appropriate way is key. And it's what happens to the data next. And so maintaining privacy is important when it comes to understanding the individual patient context. That's key for delivering personalized care for that patient. However, when it comes to healthcare system transformation, I think being able to extract that data, anonymize it so that you could remove it from any patient context, but be able to leverage its value and its capability in an aggregate form to be able to determine systemic improvement opportunities, is still possible. The technology to maintain privacy while enabling you to analyze the data in a way that is transformational does exist, and a number of companies are doing it out there. We do it ourselves. There's all the popular people who do it, and of course, I know with the eClass system and some of the talks we're having, we can do it together. And that's kind of some of the partnership we're doing with InterSwitch as well.
If I just add to that discussion, I think it's really important, especially when you're inviting the whole world onto plan types like what we offer, where we are bulk purchasers. Now, there are two things that we need to think about when we think about data privacy. All right, there's the individual's view of it, but there's the system's view, like he was saying. From a systems perspective, all right, and this is where technology is so critical, the world and the practice of medicine has become fairly specialized. If you want to pull all of the expertise together at once to be able to provide life-saving care, it's important not to put the data in sequential buckets. So it means that multiple people or multiple institutions are going to need to have access to data simultaneously. So we need to think ahead from the beginning. How do we, as patients, because everyone gets to be a patient at some point, how do we accept the nature and use of our data to provide us care, to ensure that when we need it, it's available and the people have access to the information? But technology helps to provide pockets of ring fencing and security around how it's used to maintain privacy, while we acknowledge that all these experts have access to the information in a timely way to provide us the care. This is the principle on which instruments like Apple Watch and Fitbit and co., that's what it works on. One. Two is that when you think about development, and for a market like ours, and what do you call that? What do you call ourselves? Developing economy, yes, that's the word. A developing economy. It's important for us to be able to take the data that we have on an anonymized basis, to be able to predict, plan, and determine what is the best way to give care to a large body of people. They call it population health in a different language. But in doing so, the truth is we must use the data that we have. We must use it to predict, we must use it to estimate, we must use it to plan. And that means having access to that data. So in essence, all of us have to accept that, yes, while there's privacy of data, but that data is in fact being used in ways to improve our ability to get better care.
All right, thank you so much, panelists. It's been a fantastic session, and we greatly appreciate the contributions that you have made. And we'd just like to thank you for your opportunity and time in making these contributions. So thank you once again, and please give them a round of applause for their wonderful contributions.